Great. So hi, everybody. I'm Lindsay Sizemore, Viral Hepatitis Program Director for the Tennessee Department of Health. And as always, I'm going to be your facilitator for these sessions. Next slide. So today's agenda will include introductions and announcements, a few quick highlights from our last session that I wanted to make sure everybody heard, a didactic presentation on initial hepatitis C evaluation by Dr. Alfaro Cruz, an adult case presentation, and some closing remarks. So first, some in-chat introductions as well as some brief announcements. So before we get started, I'd like everyone to take just a second to introduce themselves in the chat. Please include your name, role, organization, and if this is your first echo session with us. Repeat customer. I love it. That's great. Okay, next slide, please. So also a few quick reminders I want to highlight that you may have seen when you joined the session. So if everyone could please, including the subject matter experts and TDH team, can take 2 minutes to complete this sign-in sheet. You can utilize the QR code pictured here on the left of the slide or the website, which Shamia will put in the chat. The sign-in sheet is required for our accrediting body, and it's the only proof we will have of your attendance as far as they are concerned. If you don't complete the sign-in sheet, you won't be eligible for CE, but even if you don't want CE, please complete it. So I'm going to give everyone a minute to complete the sign-in sheet, and once you're done, please give me a thumbs up. And Dr. Chastain, I didn't know if you wanted to give your evaluation announcement while folks are signing in.
Sure. Hey, everybody. Sorry, I had a couple technical difficulties in connecting. My name is Cody Chastain. I'm a subject matter expert for adult hepatitis C infection. I'm an infectious disease physician at Vanderbilt and part of your Project ECHO team. I also serve as the principal investigator for the Southeast AIDS Education Training Center, and part of what allows me to participate in this and a lot of other educational opportunities for your clinic and your programs is for us to track who participate in education programs that I volunteer for. So I believe that Chloe Tipton, who is one of our great project managers and program managers on our team, had dropped a link in the chat. So if you're willing to complete a registration link for us as well, I appreciate it. Thanks so much.
So to recap, introduce yourself in the chat, please sign in, and please complete the registration link that Cody was talking about in the chat. I'll give you 1 more minute and then we'll go on. Okay, next slide, please. So please turn on your video and mute yourself unless speaking, and please come off mute to ask any questions that you may have. Anastasia, has anyone joined by phone only?
Nope.
Great, thank you. Please also never discuss PHI, and please treat everyone with respect. So let's dive right in. First, I'd like to highlight a few important things discussed at our last session. So first, Dr. Chastain noted some very interesting statistics related to hepatitis C transmission, and specifically the different transmission risk via vaginal intercourse or oral sex in one study, where the rate of incidence was determined to be 1 per 170,000 to 190,000 unprotected sex acts. In another study that analyzed 80 qualifying reports regarding the evidence for or against sexual transmission of hepatitis C, it was determined that incident rates of hepatitis C infection among HIV uninfected men who have sex with men have varied between 0 cases per 100 person years in Amsterdam to 1.5 cases per 1,000 person years in the United Kingdom. It was further noted that injection drug use was a common practice among the patients living with hepatitis C. It was also determined that the situation is entirely different for men who have sex with men living with HIV, especially those who engage in sexual practices that are more likely to cause anal mucosal damage. And the relevant articles are linked at the bottom of the slide if you would like to read them. Also, Gina highlighted 3 different articles that describe the different ways to define hepatitis C reactivation, as well as other terminology, including resolved, flare, acute exacerbation, and viral reactivation. This slide describes the key takeaways and the relevant articles for each section, which are also linked at the bottom of the slide. And I see that Shamia has also put them in the chat. I didn't know if, not to put you all on the spot, but to totally put you all on the spot, would any of our SMEs like to share their thoughts on these definitions and others pertinent to Hep C disease progression? I'm echo pausing. Aren't you proud?
So I will weigh in a little bit on this. I think what makes this challenging is that different terminology is used in a variety of different aspects. Some of these are really relevant in different settings, but things like flares, acute exacerbations are 2 that I think are less relevant for the vast majority of care occurring in the outpatient setting. These are things that are often relevant in very complicated patients who have had specialty follow-up aspects, but it's not the typical or the usual aspect. I also find that the term reactivation to be biologically important and in clinical studies, but it's less clinically relevant because it simply means that there's a change in the volume of hepatitis C RNA. But I think what we usually care about is resolution or resolved infection. And then what I think people often care about is the concept of relapse, which is when patients have been treated previously or thought to have spontaneously cleared and have a relapse of their original infection. And I think that's a term that we often use clinically and is also in the literature that is not covered here. And it's often one of those that are often used in the outpatient setting. All of these are absolutely correct. I think these are all very unique in the context of interpreting a specific patient's laboratory profile and the timeline related to that profile.
Very helpful. Thank you, Dr. Chastain. Anyone else?
So just to throw a question out there, where would you put reinfection as a terminology in all of this? Because I know sometimes I feel like anyways, it gets really tricky listening to clinicians talk about reinfection versus, kind of treatment failure or relapse as you were talking about as well.
So I think to define something as a reinfection, we often get into the context of whether this is confirmed or whether this is suspected. And also to document if someone having a reinfection, you also have to have comprehensive documentation that the prior infection was either resolved, either due to natural history and immune status or to prior treatment, which often means we have to have quite a bit of documentation of antibody and RNA positivity, negative tests subsequently at appropriate timeline after, and or treatment, and the appropriate laboratory test to follow up. And I think that's where we often get into these challenges about talking about relapse of an original infection versus reinfection, is that we often have to adjudicate that with limited data sources. And so that's where it gets troubling, is whether something is a relapse of a prior infection or if it's a reinfection, because that's all based on laboratory data, treatments, comprehensive data that's been obtained at the right periods of time. And I think that's often where clinically we get stuck into a place where something could be a reinfection or could be relapse of a prior infection. And we often have to use our best clinical judgment. Ultimately, the great news is that with newer therapies, often, whether it's a reinfection or if it's a relapse of a prior infection, we often still have great options to manage those patients. And it really just comes down to what option we think is the best fit. Clark, I know you help facilitate refills and medication prescriptions for a variety of folks. What are some of the things that are challenging that you see for your providers in that space?
The main thing is communication with patients, being able to get them to come back to clinic for SBR12s. I keep a spreadsheet of pretty much everyone who has been through Regional One Health's hepatitis C clinic, and inevitably patients won't come back for cure determination, but I keep them. Eventually, they will show back up in the clinic setting, maybe in an emergency room visit or maybe in a different clinic, and I'm able to get lab values then. And then it comes a question, if they do screen positive at that time for a positive viral load, it will be a question of, was it a treatment failure or did they get reinfected because the laboratory value is such delayed from when the SVR12 would have been done. That's kind of what our main issue is, just getting patients to come back to confirm SVR12s. Most patients, because they haven't been on the medication for 3 months, they don't really see the incentive to come back. I always do my best to counsel them pretty heavily on making sure they come back, but patients change phone numbers, they change addresses, things like that, and they just don't come back to clinic. So that's kind of what my challenges are, is just being able to keep an open line of communication with them throughout the whole process to cure.
So Clark, just a question there. Do you have the ability, does the electronic health record flag when they come back into the ED on somebody that you know needs SVR testing? Or do you have some other way to check that yourself and be able to add on that to other blood work that they might have had drawn for a different reason?
Yes, great question. So we don't have anything in place that could flag any patient who's had hepatitis C to like flag on my radar. What I do have, it's more of a manual process. We do have a hepatitis C lab report that I do run every morning. I screen patients, one who screen positive for a viral load, whether it be in the hospital setting or in any of our surrounding clinics. We screen them here. We also screen at our satellite clinics within the Memphis area. And then they also screen for hepatitis C antibodies. So that's an initiative we have in the emergency room here at Regional One Health, where anybody who comes to Regional One Health emergency room within the past 6 months, if they haven't had hepatitis C antibody drawn yet, we will draw one once every 6 months if they are continue like a repeat flyer in their emergency room. And so when I see that they have screened positive, I will subsequently order a viral load onto their lab work. I'll just order it under one of our infectious disease doctors who are totally comfortable with me ordering labs. As long as they're still in the hospital, I can hopefully get that information, that lab collect before they leave, and hopefully I can get a good phone number to reach out to them. So it is a manual process. It works well because I am the one person doing it. I haven't had any need to add another person or a technician into that process. But as far as the process, it is manual, but I do look at that daily. That's kind of the first thing I do in the morning, is to look at who screens positive for antibody and then who's also screens positive for a viral load. It also sends me the not detected as well. That way, if I see their name, I recognize them. I've been doing this for 5 years, so I recognize the name. I'm like, oh, she was treated in 2020, but she just now showed back up in OB clinic and she's negative. I can send her a message, or I can reach out to her on the phone and relay the message to the provider's office that she was treated and cured.
Super interesting. Thank you. I also see that Dr. Debbie Allen, so for those of you who haven't realized, we have 2 Dr. Allens, so that's why I'm always calling them by both their first and last name. So thank you, Dr. Clark Allen. Now, Dr. Debbie Allen, I saw that you put something in the chat. Would you come off mute and talk about that a little bit?
We have the same problem with having patients come back for SVR testing. And so every 6 months or so, I go through all the charts and I see who's overdue. And we just write a note. I write a note on the front of the chart that says, should patients show up at any health department, please send a Hep C to the state lab and flag me.
Great, thank you. All right, any lingering thoughts before we jump into our didactic for today?
Hey, Lindsay, it's Laura. I just had a quick question for Dr. Chastain. So whether it's a reinfection or no infection, does that change your treatment plan?
And so if someone is reinfected with a new pathogen, whether it's the same genotype that they had previously or a different genotype, the patient may be treated as if they're treatment naive, as if this is the first time that they've been treated. It's no different than how we think about sexually transmitted infection management or other aspects. If someone's treated for an infection and they later get infected, we can treat them with initial recommended therapy. If a patient has a relapse of a prior infection, meaning that they have and they were previously treated, so they were treated and they were did not achieve a sustained virologic response. If they were treated with a first-line regimen today, we do have alternative recommendations. There are medications, still single tablet or modifications of our first-line regimens that we treat patients for if it is their second time through modern direct-acting antiviral treatment. And that's why trying to adjudicate whether someone has been reinfected or if someone had a failure of prior treatment is important. And that's why clinically, sometimes we have limited information and we have to discuss, do we think this is a reinfection? Do we think there's a prior treatment failure? Because there are differences in our recommendations between those two cases.
Thank you.
Great, thank you. Okay, next slide, Heather, please. All right, so with that, I'm going to turn it over to Dr. Alfaro-Cruz to provide our didactic presentation for today. Dr. Alfaro-Cruz, please say next slide when you would like us to advance the slides for you.
Thank you. Hi, good afternoon, everyone. Thank you for joining us today. I'm going to talk about the initial hepatitis C evaluation that we do in children. Please feel free to ask any questions. Sometimes it can get a little bit tricky when we're talking about testing, but if you have any questions, put them on the chat and hopefully we can help you. Next slide, please. I have no financial disclosures or conflicts of interest to report. Next slide, please. So why is this important? Why doing an evaluation of Hep C is important in children? So according to recent studies of Gower and colleagues, about 115 million people in the world are infected with Hep C. From those, 11 million are actually younger than 15 years of age. And although children represent only a small proportion of Hep C virus infected population, the fact that a kid can actually have chronic Hep C infection can lead or increase risk for severe liver disease and other complications once they get to adulthood. According to some estimates, the worldwide economic burden of Hep C for children and their families, it's close in the hundreds of millions of dollars. And the US alone has spent over the last decade in just screening, monitoring, and treatment in children close to $200 to $300 million a year. So when you talked about the health cost, we also have to estimate the emotional burden. And that's something that it's affecting more and more our families and children infected. And it's actually harder to estimate. Next slide, please. So we know that perinatal transmission, it's by far the most common source of Hep C infection in children. And this is actually probably accounts close to 1,500 new cases per year in the US. And although many of cases still remain undiagnosed, the incidence of Hep C vertical transmission, it's close to 1 to 7% in Hep C RNA positive mothers. We know that there is an increased risk of perinatal transmission if the mother has high viral load of Hep C or if she is a untreated HIV co-infection. Now, we do know that the perinatal transmission is by far the greatest, but also we have to be mindful right now that we are starting to see more cases in adolescents of IV drug use, and that actually can put them, or it's putting them at risk to get a Hep C, HIV, or Hep B as well. Next slide, please. So this is kind of a small diagram to show what can happen, right? When a child or when an infant has been exposed during the perinatal period, a mom who has Hep C infection gives birth to this baby, to this infant, and there's can be two routes. The first one, it's talked about spontaneous clearance. Usually we talked about that as an infection that was acquired during infancy and more likely will clear spontaneous. Right now, current estimates are that the clearing rates are close to 20 to 45%. Some other studies mention 50 to 55. I like to kind of be between the 35 and the 40%, but we can see that. And we know that usually genotype 3, it will be the one that it's most likely to get clear. A lot of the times by age 3 is when we kind of have that cutoff where we know that it will be the time where if they pass that age, it's less likely it's going to get spontaneous clear. Now, we go on the other side, right, of the diagram. And this is the other scenario. So we know that Hep C liver disease will actually progress very slowly. Serious consequences like cirrhosis and hepatocellular carcinoma are very rare to happen during childhood. And some studies have shown that sometimes it can take up to 30 years to actually see develop of liver disease, right? But other studies, and these are small study populations, so that's why I want you to take it with a grain of salt, have shown that yes, we can start seeing in some cases fibrosis associated with Hep C, or in some rare cases, cirrhosis and bridging fibrosis as well. Usually in those kids, we actually tend to see more that they have other cofactors. The more important one that we have seen is obesity. And that is really becoming a problem right now because we are seeing more and more obesity in our children. And that's actually affecting the state of Tennessee as well. So it's something that we're going to have to take into account when we're doing evaluations on children or adolescents, and we're thinking about Hep C and other sources of liver disease. Now, there was one study that looked at 121 patients with Hep C. 80 of those patients actually had some type of fibrosis, and it was mild fibrosis. 2 of them had cirrhosis, and then 5 of them had the bridging fibrosis. Now, interesting, most of those kids, I think the study talked about 85% of those kids had obesity or some other cofactor that was probably driven more the disease as well. Next slide, please. So when we talk about the symptoms in kids, and I think this kind of mimics a lot what Dr. Chastain talked last week, is we really are not seeing a lot of symptoms, right? Don't expect that this is going to be a very sick children, that it's going to show portal hypertension, splenomegaly. No, most of these kids will be asymptomatic. Liver disease, it's very uncommon to happen during childhood. And when it occurs, or when you start seeing signs of cirrhosis or fibrosis, you have to think about other cofactors too that may be affecting their liver as well. You can see in some cases elevated liver enzymes, but these actually are not going to correlate to the disease severity. So even though you can find them, think that it's not going to be a good marker to see how severe that children's liver is acting up. Next slide, please. So what do we do regarding screening, right? We talked about a little bit the symptoms. We talked about how are we going to, what are the 2 progressions? So who are we screening right now? So this is a little bit more straightforward. And so right now, you have to screen any child who has evidence of clinical hepatitis, that he's asymptomatic, you have an elevation of AST and ALT, and you really cannot explain why he has that elevation, right? The other one is infants that are born to mothers that are infected with Hep C, or moms who have a history of IV drug use, who actually had siblings or other children that are born or have chronic Hep C, and they're born to the same mother. You also have to screen children who are international adoptees or refugees. And remember, because the screening in different countries varies too, so you want to make sure all these kids are getting screened. We have been seeing increased incidence and prevalence in children coming from China, from Russia, from Southeast Asia. So this is part of your screening when you get that kid into the clinic. Kids who have adolescents or children who have HIV infection, those adolescents or children who have been victims of sexual assault as well, or those who actually report that they have multiple sexual partners, those have to be screened. And also the kids who you are suspicious that they're using IV drug use, or they have history of IV drug use, especially with the opioid epidemic right now, heroin use, you have to look at the situation, at the social situation that we're living. And even though you say, you know, a 13, a 14, a 15-year-old are not using that, you actually have to start thinking about those possibilities as well. Next slide, please. So this is actually taken, and you can go into the website and it's below there. That kind of tells you what are we doing right now? What is the Tennessee Department of Health doing regarding the testing recommendations, right? And this is where it kind of gets a little bit tricky sometimes, but we have divided into if the child is 2 months of age to less than 18 months of age, and then 18 months of age and older. So if you have a child who is 2 months of age or less than 18, right now, the updated recommendations are actually prioritizing early testing. And the goal of that is because you want to minimize the loss to follow-up. You want to make sure we get that kid on board. We start tracking and we start offering treatment when he reaches the age. So we have kind of a two-step approach. And the first one will consist, ideally, you get that child in one of the well child cares, ideally between 2 months and 6 months of age when they come for their vaccinations, when they come for the well childs, and you will obtain a hepatitis C virus RNA. Now, at that time, that result, if negative, it can actually help a little bit to reassure the family that a Hep C infection is very unlikely, but still will continue to follow up that patient. Now, in the case of those who comes back positive, you will actually refer or report those results to the Tennessee Department of Health. And then we can talk to the family that although he's positive, that does not necessarily predict about a chronic infection because a spontaneous clearance can still occur. But that is a patient that you're going to follow really, really closely. You have to make sure the family is on board, knows the results, so they are aware of what's going to be the next steps. Now, the second step is when they, so I have to make clear something. You don't have to repeat Hep C virus RNA. You don't have to get every 6 months. No. Once that kid got that Hep C virus RNA, then once he turns 18-month-old, you are going to repeat a Hep C virus antibody. And that's going to be regardless whether he was positive or negative, but you're going to repeat that Hep C virus antibody. And if that is positive, it's going to get to all the other steps where you're going to, again, actually it's going to automatically reflex into a Hep C virus RNA, and you're going to be able to say, okay, this kid does have an infection with Hep C, and then what are the next steps that are going to get us to treat him when he turns age 3, right? Now, if the kid comes in for you to see you, and he's 18 months of age and older, then the testing goes straight into a Hep C virus antibody. You don't have to do first a Hep C virus RNA. You'll do the Hep C virus antibody. And then most of our labs right now are actually reflexing into the Hep C virus RNA, which I really like because it's a way of, you don't have to think about it. You just automatically, if that Hep C virus antibody is positive, perfect, reflects automatically to Hep C virus. And then at that time, if it's positive, then you can confirm that he has the infection. Now, and we'll talk about kind of what are going to be the next steps to follow up. But when you're going to talk to the parents that when he reaches the age of 3, then at that time, we'll repeat another Hep C virus RNA. And then because he has the age of 3, we'll start with treatment ahead. If that Hep C virus antibody is negative, then at that time, you can confirm that there is no Hep C infection. Next slide, please. So what happens after that? So usually, and this is where it changes a little bit compared to adults, we will obtain a Hep C virus genotyping. And although right now, most of the medications that we have, or all these direct acting antiviral agents, have activity against all HCV genotypes, we do need to get it because most of the public or private treatment programs will actually require a Hep C genotype to treat children. They want to confirm that he has infection in order to approve treatment for that. So that's what you're seeing, that most of, or I would say probably 95 to 100% of our kids will have a Hep C genotype before we start treatment right away. Now, liver biopsies are not indicated. Nobody is going to ask you that a liver biopsy needs to be performed in order to treat the child. Sometimes, if there is concern for fibrosis, cirrhosis, you'll get a liver biopsy, but that will not delay the care of the children. You need to get a hepatitis B panel. You need to look for a hepatitis B infection, HIV, and hepatitis A would be the other test that they will ask you to get to make sure there's no co-infection with those. Next slide, please. So what do we do? So there comes, it's easy when you have a child or an older kid who comes in, he's after 3, you get the diagnosis, and then you can start treatment right away. But what will happen during that window when we have an 18-month-old, we have confirmed an Hep C infection, and you can still do not treat because the medications are still not available for that age group. So you're going to monitor for disease. Usually we tell them to follow up with their, in this case, PCP, every 6 to 12 months. They can get aminotransferase levels just to kind of evaluate how things are going. Although remember that this is just going to guide you, but it's really not talking about severity of disease. And then you're going to do your physical exam, making sure there's no signs of portal hypertension, splenomegaly, any of those symptoms as well. Next slide, please. So we talked about the testing, right? So, and this is important because you really don't have to be repeating Hep C virus RNA constantly. This is not the case. There are exceptions to this rule as well. And for example, that will be if you had a kid who had Hep C with elevated ALT levels, and suddenly after 12 months, they become normal. So in that case, you can actually measure Hep C RNA to determine if the child has spontaneously cleared the infection, because that will definitely say this kid does not need treatment anymore. Or if that kid has reached the age of 3, now we have available medication to start at that age. And of course, you need to make sure you need to document. And so that's when you repeat it, or that the child has active Hep C before proceeding to treatment as well. So those are going to be the exceptions to the rule. Next slide, please. And I put this slide here because this is not the common thing. It's going to be very rare. There's not that many hepatologists that actually seen that occur from Hep C, but you have to be aware, right? That yes, there is a risk, especially those who have cirrhosis, those who have co-infection with Hep B, or who have history of leukemia or other cancer are definitely increased risk to have hepatocellular carcinoma. With cirrhosis, if the kid has confirmed cirrhosis, you have to get liver ultrasound, you have to get alpha fetoprotein levels in these kids, and you have to monitor closely. Now, education, it's key in these cases because you need to let them know that even though they have been treated for Hep C and that they have eliminated the infection, that in the patient who has cirrhosis does not necessarily eliminate the risk of getting hepatocellular carcinoma. And this is just something that I think applies more to the adult population, but because there has been rare cases, you have to be conscious about that when you talk to the families. Next slide, please. And so this, I think it's my most important slide today, and it talks about educate, educate, educate. So one of the most common questions that I get asked from parents is, can they go to daycare? Can they play with their siblings? Can they go into the pools? Can they share with other kids? And the question is absolutely yes. You don't need to restrict any routine childhood activity. We need to actually, these kids and their families are facing a lot of discrimination, a lot of the stigma surrounding around the diagnosis. In fact, there is nothing that says that you have to disclose a child's Hep C infection status, and you have to educate them, because I don't think we're doing a better job right now at treating it, but not taking away the stigma and the discrimination that comes with having this type of infections. And so what I always tell them, he can have a normal life. You can forget, but be careful and use the universal precautions, right? Things that we will always do, no matter if you're healthy or not. Like do not use the same toothbrushes, do not use same razors, nail clippers, use gloves and bleach if you see a lot of blood coming up, right? So you have to be mindful that they can have a normal life, because that's what we're seeing more and more. And that's what the emotional burden is playing a role, because a lot of kids are being not exposed to the things that normal kids will be when they actually can do it. So this is something that I want you to kind of take across, because we spent, and it has happened, we spend a lot of time talking about this is what diagnosis, this is what's the test going to be, this is how we're going to treat. But then we forget this important part of a child's life, right? That they can actually have a normal life. They can do all their childhood activities that they would do. And there's no reason that they have to disclose this at all. Next slide, please. So before we go to the Keith's presentation, I think we're going to take a pause, and then I don't know if anyone has questions.
So I'll get us started with a question. So just to clarify, it's my understanding that RNA testing for children can happen as early as 2 months. And you mentioned kind of repeat testing versus not repeat testing. So it sounds like there are some benefits to testing again, but really it wouldn't need to be completed until really close to that 3-year mark when treatment's truly being initiated. Is that correct if you're doing
Yes.
early testing like that?
Yes, that's correct. I think a lot of comes with the fact that the parent gets very anxious, right, about having the diagnosis. And when we talk about spontaneous clearance and what can happen, so I think that's what's happening, that some people will actually test sooner. But to be honest, I think if we are able to provide education to the parents and say, listen, nothing can be done between 18 months and 3 years of age, we will follow closely, right? But I think it's better to kind of get closer to that 3 years of age when you know if they will actually spontaneous clear or not, and then you repeat the test.
So I don't have a question, but I have a comment. So the last slide that you were discussing about the importance of education, I mean, I think that is, just to reiterate, so very important. Laura Price does a lot of work with DCS because unfortunately a lot of these kids are in foster care and other situations. And Laura, to put you on the spot, can you talk a little bit about like why that is so important to educate?
I think identifying the guardian early is key because things can change. So the DCS piece, it's very, they make sure that they're notifying those foster parents who then take the child to the doctor. And they really do a really good job of ensuring the child is tested. And I also worry about, like Dr. Alfaro Cruz talked about, the loss to follow-up. And that happens many times because we lose track of that child and which PCP they're going to. So that's why I think I'm really excited to see that we're really going to encourage this earlier RNA testing, because I think it's going to keep these kids healthier. So is there anything else, Lindsay, that you wanted to hit on?
So I know, Laura, I don't remember where we were, but this is a while back, they were just talking about, there have been cases of foster parents kind of use, like when they find out about the hepatitis C status, right, then they kind of maybe will treat that child a little bit differently. And so it's really important to kind of on the front end educate about there's nothing different with this child. You don't have to treat them any differently, because otherwise you could get into a situation that, you know, no child deserves to be in.
Yes, and we do include that. There's a separate guardian letter that's included in the outreach to the DCS nurse consultant. And in the guardian letter, it spells that piece out of what they need to be mindful of. But the child can participate in everyday life, go to school, like you said, go to school, go to daycare. We talk about the toothbrush, the nail clippers, those sorts of things. So it really is in line with what you mentioned.
Thank you, Laura. Any other questions?
I think one piece that I want to reiterate, and then we talk to the parents too, because when we treat them so early in life, right, we tell them, when they get older, this does not mean that he's lifelong protected, right? And I think it goes what we were talking about, reactivation or reinfection. When they get older, if they start using drugs, having unprotected sex, like this is not something that is going to protect them for life. And so we have been trying to be more aggressive in explaining our parents, I think, that it's not giving you lifelong immunity. It's not giving you a free pass, because it can happen as they get older, they can actually get infected or reinfected in this case. So it's something that we do explain to them when we're offering treatment. And we talk to the moms too, like, make sure you're getting treated. If you're actually, and that's kind of part of the education, if you're going to have more babies, that can happen again. So that's something that we're also providing education at the same time.
Also really important. Go ahead,
Yeah,
Laura.
That's really important, especially, and this is what I talk about with moms, is that as we're coming out of COVID, there's been so much talk about antibodies and protection that's what I use as my example, is that, you hear about antibodies in that way, but that's not true of hepatitis C, that any risk factor puts you at risk.
All right. Any other questions? Any from our other SMEs? Echo pausing.
Clark, just wondering if you all are treating pediatrics at Regional 1.
Good question. So right now we are not. The earliest patient that I have treated here was an 18-year-old. He was a vertical transmission patient case. I actually treated the mother as well, which is how we were pretty confident it was vertical transmission and not any other risk of transmission. So I was going to actually reach out to Le Bonheur, which is across the street from Regional One Health, sometime this month to kind of ask what their procedure is for if a patient trains positive there at Le Bonheur, what happens? Where do they go? They probably have a process. I just don't know it yet. So that was kind of in my plan already to reach out to them as we're coming up on talking about initial treatment options next month.
Hey, this is Kathy Knapp. I'm at St. Jude in Memphis. I see HIV exposed infants, and we recently had a baby who does not have HIV but did have hepatitis C infection. And I don't know what the Le Bonheur process is, but we referred him to Dr. Eschen in the GI clinic there. So I know he sees and treats patients there.
Also, Dr. Allen, plug our echo. Invite them to our echo if they want to come. We would welcome them.